Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Hello, and welcome back to the Fix Podcast. Super excited for our guest today, Dr. James Rutkowski. He's on. I got connected with him through Dr. Todd Erickson, so shout out to him. He was a fan of our show, had been listening to us for quite some time, and he wanted to tell us about this residency program that he was directing. And we talked a good bit about what they were doing over there. And, you know, there's not a whole lot of residencies that when people reach out to us and they're asking about what kind of programs that they should be looking into out of school if they're trying to get into, you know, implants and are really serious about surgery. There's not a lot of programs that we really point people towards, not necessarily because there's not good programs out there, but just because it's hard to find programs that are really a specific funnel for what it is that we do. And as soon as I heard about the kind of caseload that these dentists are able to do, I was really impressed, and this is certainly a program that I'm steering people towards myself. So he referred me over to Dr. James Rutkowski. We have here with us today, who's going to be talking about the Jacksonville University Comprehensive Oral Implantology Residency Program. It's a bit of a mouthful, but that's because it's a load of content as well. And so I'm really excited to hear about all the things that you guys are doing and hear a little bit about your story. So Dr. James, thank you so much for coming on.
Well, thank you for the invite, and thank you for the interest in our program.
Of course.
It's really appreciated that there are people that want to see to it that those that are doing implants get the finest education that they possibly can get. And that's what drives our program and drives all our residents. So thank you for having us.
For sure. So I'm hoping that you can give us a little bit of context, really about yourself and your own background in implantology, how long you've been doing it, your own training, and just kind of walk us through what got you to being the program director that you are today.
Okay. Well, I started out as a pharmacist. I graduated from Duquesne University School of Pharmacy in 1972, and from there I went directly into dental school, where I graduated from the University of Pittsburgh in 1976. And then I went into general practice, and I immediately saw that there was a real problem with patients who were missing teeth, particularly full arches, that lower dentures in particular. There was nothing that you could do that would really make it work. Occasionally, maybe you get the 1 or 2 in 100 that just said, I love my lower denture, but you got 98 people who said, isn't there anything better, doc? And distal extension, partial dentures and whatnot. So I started taking implant courses from Midwest Implant Institute with Dr. Jack Hahn and Dr. Duke Keller, as well as many other people, Lenny Linkow, those people that have gone before us, and I've been able to stand on their shoulders and see what was possible. They took care of a lot of the initial issues for us. I placed my very first implant in 1983, which we did not have any kits. Went to the hardware store, got some drills, got some things that we called osteotones. They were really leather awls. We sterilized them, we tapped holes in bone, and we put these implants in. And I could see that there were some real issues with the way we were doing things, but it was all that we had. I stayed with it, did a fellowship with the Midwest Implant Institute, as well as other courses, got very active in the American Academy of Implant Dentistry, the AAID. Continued on, got my associate fellowship, my fellowship with the AAID, and then my diplomate status with the American Board of Oral Implantology and Implant Dentistry. Was doing a lot of bone grafting. I was one of the earliest adopters of implant dentistry in Pennsylvania, in Western Pennsylvania, where I practiced. I moved to a small town because that's where my wife and I wanted to raise our children. And so there I was in central Pennsylvania in a small town and wanted to do implants, and people said, you'll never do them here. But lo and behold, there were people there that needed implants, and we started doing them, and we traveled, and we built a practice that was very heavy into dental implants. I was doing a lot of bone grafting. I realized that we had a lot of deficiencies with bone grafting, and my wife and I became empty nesters. Our kids were out of college, so I decided I would go back to school. I always had a strong interest in pharmacology, and to me, everything that we do is pharmacology, whether it's signaling of the bone cells to go ahead and start osseointegration or de novo bone formation for us. So I went back to Duquesne University. I kept my practice 3 days a week, but I went back to get a PhD in pharmacology at 51. Wow. I finished that 7 years later. When I was 58, I put a research laboratory in my office. I actually hired technicians to help do that research. I had to know how all the research was being done because I had to do my defense, but actually doing it, I had people that would be working with all the cells and doing all the things for it and whatnot. And so at 58, I graduated with my PhD and started to put some of those things into practice, into clinical practice. Opened up a research company called the Clarion Research Group. We developed a small molecular compound, small molecule, that synthetic that shortens the sigma for bone formation from 16 weeks down to about 10 to 12 weeks predictably, and started to work with some people in orthopedics, and our product started to be used in spinal fusion on a research capacity, clinical research, as well as dentistry, and also took a strong interest in postmenopausal women and the issues they have with bone formation and their estrogen levels. And so we did a lot of research with that with the research company and Salivary Diagnostics for these people, so these individuals. So it's been a great ride. I continued to practice until I was 70. Although I must admit, beyond the age of 60, it was only 2.5, 3 days a week because I was involved in the research the rest of the time. And I left clinical practice in July of 2020, and I was doing just fine with all the things that I was doing. I was doing CE lecturing with maxi courses as well as other invites, and was enjoying life. And then the Jacksonville University program, they reached out to me and asked me if I'd become director. And I said, no, that's okay. Everything's fine. Thank you for thinking of me. And they came back in about a month, and they said, well, you're going to do it. And I said, well, actually, I thought I answered that question. And they said, well, we'll give you another month. And I said, well, I don't think it's going to change. And then the dean called me, and he and I hit it off. We hit it off, and my wife could overhear the phone conversation. And she said to me, well, how did that phone conversation go? Remember, you're retired now. You don't do everything. And I said, yeah, but I'll tell you what, I think we can make something happen. And so I said, sure. And I'm glad that I did. It's kind of like, when you go to the dog pound and they hand you the puppy. Once they hand you the puppy, you can't give it back. You're going to take it home. And that's exactly what happened with this program. I'm very energized by our residents. They are outstanding individuals. They are dedicated. They want to do the very best they can. And that's what drives the entire program. Let's just make the best educated implant dentists, because implant dentistry is so complex, whether it be the surgical component of it, the bone grafting component of it, just taking the tooth out. How do we get the tooth out? What are we going to do to grow the bone, put the implant in? And that old excuse, why I put the implant where the bone was, yeah, that worked in 1988. It does not work in 2025, though. Mm-hmm. And so we know a lot more now than we did in the 80s and 90s, whether it be implant surfaces, thread design, treatment planning, methods of treating, prosthetics, everything, pharmacology, medical evaluation. All these patients that come in, they are in their 70s, 80s, and 90s. They have a long list of pathologies and a long list of medications, and all those things do affect the results for us. So we've just put together a program where we get to be able to bring everything together to help these young doctors and middle-aged doctors. I'm surprised at how many middle-aged people we have coming into the program.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Wow. Yeah, that is quite the illustrious career. And I really commend you for your commitment to education and taking on all the things that you took on. I mean, having a doctorate in pharmacology, in addition to all the things and your contributions to implant dentistry and the research and everything, it doesn't seem like you've had enough time to do all the things that you've done. So I really commend you for all that, and also praise you for continuing to recommit yourself to a whole new thing into your 70s. So that's really fantastic. And there's a lot of different avenues we can go down, and I'm also very curious too, and we can certainly get into this, aside from talking about the residency itself, is, you kind of already alluded to it, is, I think your pharmacology degree has only become more useful over time because polypharmacy and what we do is more common than ever before. I mean, I've had a patient, I sent it to Dr. Poppy as well, that had literally just 20 pages of prescriptions. And I said, I'm going to look through here and see about the things that I know about that are going to be contraindications. But as far as how all this works together as a system, I couldn't tell you. So I'm sure that's certainly come in handy for you. But yeah, Soren, did you have anything to glean from all that? That's quite a repertoire.
I mean, I really appreciate the fact that, we as younger dentists in the profession of implants, benefit greatly from people like you who contribute to the research and, like you said, like the advancements in grafting and techniques like that. I feel like Tyler and I have come into the implant game while there's so many things that have improved before us, and it's allowed our job to be that much easier. When, not that it's an easy job, but from where you were at in the 80s to where we're at now, we've come into the profession at such a good time where there's a lot of advancements in these techniques, and we're able to provide treatment for patients that they weren't able to get before.
And we're not going to the hardware store for our instruments anymore. Yeah, so.
Yeah, absolutely. I'd love to hear more, and I'm sure our listeners would love to hear more specifically about the residency, kind of like time lengths of it. I know you were talking a little bit about it prior to the episode starting. So just, what the residency is, how it differs from other residencies, what people in the residency can kind of get out of it. And I think that would be excellent for our listeners.
Okay, well, great. Let's just start how our residency differs from the other residency programs that are out there, whether it be oral surgery, perio, or pros, that do have an implant component to it. Those residency programs, if it's the oral surgery, then they are looking at it from a surgical aspect. And that's where they put their emphasis on it. And they do place a reasonable number of implants in their residency programs. A typical 6-year residency in oral surgery, they may place 70 to 100 implants, of which they don't restore any of them. Okay, so they put them in, and then they never get to see what do they look like necessarily, or maybe they do get one post-op when they do see the actual prosthesis in place, but they're not there and seeing, with their complications and whatnot. Perio, and they contribute, all these perio, pros, oral surgeries, they contribute a great deal to implant dentistry. and they certainly have a place in implant dentistry, but so do general practitioners, okay? Because implant dentistry is oral surgery, perio, pros, and a big component of general dentistry. So, and perio, they focus on, the soft tissue, the aesthetics. They know the literature extremely well. They contribute to the volume of literature greatly. Pros, who knows prosthetics better than a prosthodontist? Absolutely nobody. They know their literature and whatnot, but they don't necessarily get to do all the surgical placement. Where our program brings everything in implant dentistry together. It is the diagnosis. It is the evaluation of the patient. It is the treatment plan. It is getting acceptance of the treatment plan. It is the surgical placement of the of the implants. It is the managing surgical complications, both immediate and maybe long-term, and how you prevent all of those. Then our program also, our residents, not only did they place those implants, but now they restore those implants. And so then they deal with the prosthetic planning. And that had to be all done before they ever started the case, obviously. But they deal with that prosthetic planning at the beginning, and then doing that prosthesis for them, then maintenance of that prosthesis. What kind of complications were there? Does the patient come back and say, I really can't get my floss threader in there, which, that wasn't necessarily a concern of the OMS. Well, you got to see the prosthodontist for that, and the prosthodontist goes, well, that's where you put the implant, and they're too close together, and that's the best I can do. So then there gets to be this finger pointing, where ours, the program is, they do it all start to finish. They do reach out and rely on the other dental specialties, though, when they feel that it is necessary. So this isn't, it's all us and just us. No, we believe that implant dentistry involves everybody. It's just that we're trying to educate a dentist who can take the case from start to finish, either themselves or in conjunction with others. So they make it all work together. Then, in our residency program, they also follow these patients afterwards. So they see what it looks like in 6 months and a year. Another big difference with our residency programs is it occurs in the real world. It occurs in clinical practices across the United States. Right now we have 21 different clinical sites where we have a total of 27 different residents. Some of the programs have more than one resident, but they are in the real world. Now that real world may be private practices where, they hear about the patient saying something about, well, I don't like the price. I don't like the fee. Or, when it's all done, I don't like the shade. Or I don't like this or that. Where that if you are in a dental school or a hospital, you don't necessarily get to hear all those things because there is a billing department that takes care of all that billing. There is a department head that has to put up with that somebody is unhappy, their complaints about the end result. And so, you got a department head or a dean who's taking care of all those things, and you're not necessarily, we're here, you are the one that's involved with this patient. You have a resident director that works with you and supervises you. They are people that are well experienced in implant dentistry, whether they are oral surgeons, perio, pros, or diplomates of the ABOI or diplomates of the ICOI, individuals that have a great deal of experience that can supervise these residents as they go through their program with it. So our program is, I think, I know it is the most comprehensive. And not only is it comprehensive clinically, but then didactically, we go into great deep dives in every single topic. I know there's topics that in continuing education, they may get an hour lecture on it or a 4-hour lecture on it, where in our program, that may represent a 6 or 8 week didactic lecture that they are actually evaluated, assessed on, because there are homework assignments, there are quizzes and tests that they have to take, final examinations, there are papers that they have to write. So there is an assessment, there are assessment tools in place where in the CE world you don't necessarily get that. And now You asked me several questions there, Dr. Poppy, and I think I only got through the first one. I don't remember all the others.
And I actually have a couple questions now after you.
Yeah, I do
after
too.
you, I think the others were number of residents, which I think you answered. You said 27, correct? And then
Yes.
I asked length of the program, and then I wanted you to elaborate a little bit on. You talked about how you get your master's in the program, but I don't think you discussed that just now. So
Okay.
a couple of those details would be great.
Great. Well, the program currently has 27 residents, of which we'll be graduating our first cohort at the end of April. That first cohort only had 5 residents, so that'll give us 22. But as of December 31st, we have 16 residents who have been accepted and are into the program. They are matched with their sites. So, but we probably have another 5 or 10 that will be coming in. So this incoming class will be a minimum of 16, but probably more. So that would take us to 38 residents, and we might actually end up with 40, 45 residents going forward. The program is currently a 3-year program, but we have made petition to the university, and the university is very much in favor of it, is to reduce the program from 3 years to 2 years. When I took over the program at the end of its first year, I took a hard look at that curriculum and I said, Ken, is there anything I can streamline here? It still deep dives into everything. It's just I'm making the best use of everybody's time. So, and the university is very much in favor of it. So I full well expect that the program will be a 2-year program. And those that came in cohort 3 in July of 24, they came in on a 3-year program, but they are going to morph into the 2-year program. It's the second and third year that got combined. The first year stayed pretty much the same. Second and third year got combined. So we'll have 2 classes of 3 years, and then the third year, cohort 3 and cohort 4, they will be 2-year programs. They are year-round programs. It's on a tri-semester, and they do their clinical work in the clinic. We want them to be in the clinic 8 to 10 hours a day, a minimum of 3 days a week. They do their didactic portion Monday through Thursday, 8 to 9:30 p.m. Eastern Time. It is done virtually. All the lectures are recorded, so they can do it asynchronously. So if somebody cannot make a lecture on a Tuesday night because a lot of our doctors, they have families, or they're starting their families, or they're out looking for a mate to make a family. So they got a date on Tuesday night, and they can't make it. So, but they can binge watch over the weekend, get caught up on all their homework. The homework assignments are usually due 2 weeks after the presentations. There are reading assignments. We encourage them to attend as many lectures as they possibly can. Some lectures they must attend because they have to do presentations to and whatnot. But for the most part, they get to do it asynchronously, which that certainly helps. But that gives us is a full-time program. The clinical portion of the program is based on entrusted professional activities, EPAs, entrustable professional activities. And they start out with the simpler things, or the things that where you would start, where it is onboarding a new patient, an examination, medical evaluation, pharmacological evaluation, dental evaluation, presenting the case to the patient, the treatment plan, getting acceptance of the treatment plan. So that's one EPA, getting informed consent and doing all that. That's one EPA. Then other EPAs, they may start out with a single implant in the non-aesthetic zone. Okay, no grafting necessary. Then maybe an immediate implant in the non-aesthetic zone. Then maybe a single implant in the posterior maxilla, where you do have to do a sinus intervention, whether it be a crest or a lateral window approach. And then posterior mandible, etc., full arch treatments, the aesthetic zone, multiple implants in the aesthetic zone, FP1s, 2s, 3s, RP3s, 4s, 5s, RP4s and 5s. So the whole spectrum of it. They do an IV conscious sedation program. that lasts about 7 months. Now that they do have to go to Dayton, Ohio for. They have about 6 visits to Dayton, Ohio for that IV conscious sedation program. But they do get their IV sedation permit. It is the most rigorous IV sedation program in the country. It is accepted in all 50 states. Some IV sedation programs are not accepted in some of the states. Ours is Dr. Steve Shuffleberger, who many people already know, is the instructor for that program, and it is a very rigorous program. So these EPAs, they go from those basic things to where they then, the full arches, as well as zygomatic implants, pterygoid implants. And if the clinic they're in does not necessarily perform some of those procedures, then they will rotate through other clinics where they may or may not be able to get to do those procedures in those clinics because they may not have a license for that state, but they will at least assist in them. Then they will write a paper on that, and then they will sit for an oral examination from me to assure that they really do have a good understanding of all of those procedures.
Wow.
Number of implants, I just talked with one of our residents who in his first 2 years and 1 semester has placed well over 600 implants, has currently restored 90% of them, and has done 60 full arches.
That's excellent. Yeah, that is a very robust education in implants.
Well,
I'm surprised you guys are even doing remote anchorage, like zygomatics and pterygoids. That's very cool.
Yeah.
So do you guys have clinical suites where so each resident is in like a different clinic, and then how does that work exactly?
Right. Yeah. So we have these 21 clinics all over the United States, and some of them are just private practices. Others are 501(c) nonprofit clinics where patients go there and they get their implants done at a reduced fee. But even in the private practices, many times those practices, they will have their standard fee, and then a patient may say, gee, I can't bite off that much. Is there an alternative? And instead of giving maybe an inferior implant alternative, they say, well, we do have another treatment method for you, where we have a resident from Jacksonville University who, instead of assisting me in this case, and they have done these cases, they've assisted, this is the director speaking, my resident will do the case, and it might be at a 50 to 75% of the normal fee. So that entices patients to stay with it. We have many manufacturers who we have partnered with who give substantial discounts to the clinics for the cases that the resident is doing. So they get the benefit of paying less for the implants, less for the bone graft materials, less for the membranes, barriers, the whole 9 yards, the digital hardware, the digital software that needs to be had. We have companies that give discounts for every single thing that is done in implant dentistry. And that entices these private practices to say, you know what, I can bring in, we call them associate residents, where they are to do whatever an associate does in that practice. That means a re-exam, a new patient exam, take care of an emergency, and if it is a just 100% implant practice, they might have to sit down and do a composite restoration. They might be doing an occlusal or a DO on number 15.
That's sadistic now.
I personally think that's harder than doing some implants.
Oh, it is.
Oh, yeah.
Take
100%.
It'd be a nightmare.
But they have to be contributing to that practice. And you know what? I tell all my residents, you know what? If an assistant calls in sick that day, or they have a sick child and they can't come into work that day, and they need someone to help seat patients, help scrub instruments, help clean rooms, guess what? And even though I practiced for 44 years, and I was 7 years old when I quit, you know what? If we were shorthanded, I pitched in and did it.
Yeah, that's right.
Oh, yeah.
That's awesome.
100%.
That's awesome. We get asked all the time about, the decision point between do I go into a residency after school, or do I just go straight into private practice and just, take a bet on taking a bunch of CE? And because, you're in private practice, you're making private practice money, you can pay for the CE, you're doing these weekend courses, the week courses and things like that. And I think it's always it's a calculus of, well, how much are you learning over a given amount of time? And, how much are you progressing, and what are going to be the returns over time for how much you've learned in that given amount of time, right? And I think the case is with so many residencies is they might be 2-3 year programs, and you might come out having placed 15-20 implants, and it's like, well, you've spent a long time learning a bunch of stuff didactically speaking, but in terms of reps, you didn't really get a ton of reps during that time, and so there's not as much of a return on investment. But what you just described in terms of what these residents are doing in a private practice environment, and the breadth of skills that they're learning and coming into contact with, all the way up to remote anchorage, getting their IV conscious sedation, which is, a pain to do while you're trying to balance, running a business or what have you, going through all these different competencies and getting that kind of volume. That is 2 years incredibly well spent that is going to, have a absolutely massive return for all of your residents for the rest of their careers. And that's really an accelerant in my opinion. And I wish this kind of thing were around when I was coming out of school, because and the fact that you guys make this available to general practitioners is just it's a career hack, and I'm really, really impressed with you guys have put together. And I love the private practice component of that. That's not something I was actually aware of before we got on here.
Yeah, that I have had discussions with a couple of dental schools, a couple of prosthetic residency programs, some AEGD residency programs, where they say, is there some way that we can partner with you, or just how are you doing this? I had one dental school recently where they actually closed their implant dentistry department because there was a internal conflict between oral surgery, perio, and pros at the school and implant dentistry, because the patients were coming for implants. They said, well, yeah, I'll go to the implant dentistry. So all the patients that needed implants were going to implant dentistry. They weren't thinking, I'll go to oral surgery, pros, or perio, and they were being directed internally in the dental school to the implant dentistry department because they needed implants. And that created an issue within the school. So they had to close the implant dentistry department because it was in competition with oral surgery, perio, and pros. And I don't want us to be in competition with anybody. I want us to just be out there giving the best education.
Right.
And that's where this dental school, they said, so let me get this straight. You have your residents out there in the real world, all over the United States, not competing with any dental school. And we said, yeah, that's what makes it work. And our residents, we want them to spend a minimum of 3 days a week in the clinic. For that, the clinic has agreed to give them a stipend of $50,000 a year. Okay. But we strongly suggest, and the agreement is between the resident and the clinic site. What we suggest, though, as the university, that if their collections goes beyond $200,000 after lab fees are paid, then they get 30% of their collections. That also allows them 2 days a week to go out and moonlight in a practice and, just make some real money. So we have many, many residents that are making 80 to 100, 150. I have one resident who's making $180,000 a year. And now I got to admit, the first 3 or 4 months, it's kind of a push. They're new, they're just learning. And then those of you that have had associates, you get an associate the first 3-4 months, nobody wants to go to them. They want to see the main doctor, et cetera, those kinds of things. It's a little bit awkward, and, they got to get their feet wet and, securely implanted on the ground. And so the first 3-4 months, it's a push. They may not be earning their keep, but then I have resident directors tell me that after they're there 5, 6, 7, 8, 9, 10 months, hey man, this is a big win for me, because I've got someone who is dedicated for 2 years, because so many times associates come in, they stay 6, 9 months, get their feet wet, and they want to go.
Right.
Where here they've got a 2-year commitment to them. And then also it's an avenue for future partnership or buyouts.
Right.
With them. And I think the associate resident model works well. The university confers a master's degree. It is not a code-approved program because implant dentistry is not a specialty. It's not a code-approved specialty program. But we are approved by and accredited by SACS, that's the Southern Association of Colleges and Universities. That's where we get our accreditation through. So we're able to bestow a Master of Science degree in dentistry with a certificate in comprehensive oral implantology. And then I'll talk about another whole avenue we have here in a few minutes.
Yeah, that sounds like a win-win for everyone. I mean, I think one of the major concerns, like you said, are in like a dental school setting or like a residency setting is number of reps, right? Like you only have so many implants that need to be placed by however many providers you have at a single location. So the fact that you guys are instead doing it where you have X amount of 21 clinics across the U.S., one, that's great for the residents because they don't need to move their entire families in some situations to like a certain university. They're still getting their master's degree and they're making an income while you call them the like head of the clinic, right? Like what was it? Yeah, resident director. The resident director is kind of a win for them because they're essentially getting an associate for like a low fee, right? Like, so it's
a hack.
It is. It's a win-win. The residents are getting amazing reps that they wouldn't get in a private practice setting. It sounds like someone's over their shoulder for some of these procedures, and
right.
I could see it being extremely beneficial. I agree with Tyler that if something like this was around when we were coming out of school, it would have been excellent. Instead, Tyler and I spent many nights up until midnight, 1 a.m. Just studying this stuff. My background is I did a year under an oral surgeon. And basically we were rounding in the hospitals until midnight every single night just to get my surgical reps in. And I know Tyler took so much CE on the weekends and he did his IV course, like all this stuff. People don't realize, like a lot of people will come out of school and they'll be like, okay, I'm going to go to these CE programs and get these reps. But what ends up happening is life just happens, right? Where all of a sudden family time, all of these things occur and it just gets pushed off and off and off and they might never get that education that they wanted to when they came out of school. So I see something like this being extremely beneficial for someone that's looking to get into implants. And another thing that, I hear from my colleagues a lot who are doing general dentistry, they get all these promises made by going into offices by associates, in their associate, they're told like, hey, yeah, you're going to get a bunch of surgery, you're going to get a bunch of implants. And then what ends up happening is they go into these clinics and the primary provider is like, well, I'm actually going to do those implants because that's the money makers, right? And you take these patients or these early cases, and a lot of times they don't get that experience that they were promised, right? So being able to like kind of guarantee those reps is so powerful, and it'll get like 2 years in a program like this is probably 10 years of CE that they would be taking outside of the clinics.
Our tuition when we go to the 2-year program will be $37,500 a year. So for 2 years, it'll be $75,000. But if you take all of the courses that we offer, both didactically and the clinical, that it comes into, with the IV sedation and everything, it comes into about, if you went out and just did it with CE, it'd be about $135,000.
Oh, yeah.
Plus,
sedation alone is $25,000.
Airline.
Yeah.
Pardon?
I mean, sedation alone can be $15,000 to $25,000. Just
yeah,
that.
Exactly. Yeah. And so you don't have airplane tickets to buy.
Right. Of course, yeah.
You don't have hotel bills, restaurant bills. You get to come home at night. You get to be with your family. You're not away every weekend. When I'm like you guys, I mean, I came up the CE pathway, and I mean, a lot of weekends.
It's expensive.
Right. I'd work till 5 o'clock, 6 o'clock, get in the car, drive for 4 hours, get in a hotel, stay there for Saturday and Sunday lecture, drive home, get back home Sunday night at midnight, 1 o'clock in the morning, get up the next morning, Monday, and go into the office and start working again all over, and miss that whole weekend with my family.
Oh yeah, and I mean, and what Tyler and I typically have done is we have to take weeks off of our clinics to go overseas, right? So you spend $2,000-$3,000 on a flight overseas, and then you have a hotel there for a week, and then you got to factor in your the cost of closing your clinic down for the week, right? Production costs for that week, on top of a course that's typically, a lot of these courses are 20,
Easily.
like remote anchorage courses, zygomatic implants. You can be paying up to $30K to get, a week's worth of a course.
Yeah.
And that's a whole year for your guys' program, which is excellent.
And when you place those implants, you never get to see did they work or not.
You're run through it.
Yeah.
I mean, you're lucky to do a handful of cases, and you don't ever see them again. You have no idea how they turned out. You're just seeing a snapshot of that process, and you're still, paying so much for it.
And I think the most important thing when going to those programs is, anybody can put a screw into bone, right? Like a zygomatic implant. I mean, zygomatic implants are obviously more complex than that. But what I'm trying to say is the complications. That's the difficult part, and that's the part that you should be paying, because once the zygomatic implant's in, that's one thing, but handling the complications after the fact, that's the most difficult part in my opinion.
You're absolutely right. And you've got to be able to experience everything that goes with implant dentistry if you're going to place implant dentistry, and you have to know how to manage it. And when you go, and I've taught those courses in Mexico and whatnot, and people come down, they do them, and they say, okay, well, I did a sinus lift. Now I'm going to go back and I'm going to do it. Then they're reaching out to me because I make myself accessible to them. They reach out to me and they say, hey, Jimmy, and I was just an instructor brought in. It wasn't my program, but I got this problem. I got this. What do I do? What do I do? And they're in surgery and they have no idea what to do because they don't have anybody looking over their shoulder. We're here. You've got an experienced director who, you can be in there, and your EPAs and trustable professional activities is after you do it. And it's not just doing each 189 things one time. No, when you do it, you record it, and then you sign it, and your resident director signs it, and you're asked the question, do you feel you could go in the room and do the next one all by yourself? And if you say yes, then you check yes. Then your director signs it, and he's asked, can this resident go into the room and do the next one all by himself? And if one of you says no, well, you know what? Then you do it again. Mm-hmm. And we want a volume of work. I don't want to see like just the lateral windows. It's not that you do one lateral window and you're done. No. I want you to do at least 5 lateral windows with no tears of the Schneiderian membrane. But I want at least 5 Schneiderian membranes torn also. Now, I don't want you tearing them intentionally. Don't get me wrong. But if you
need to know how to manage
say
it.
I've done 15 and did you ever have a tear? No. Well, then I can't sign you off.
You haven't done
because I don't know if you know how to manage a tear.
Yeah.
And it's not that you got to manage one tear. No, you got to do this 5 times. And you say, I did this and it worked. And now I know how to do it. I'm not going to panic. I'm not going to freeze when it does happen,
right.
I'll say too, something that's super beneficial that I feel like a lot of people don't realize when they go to these CE programs. And not like ripping on CE either. Like CE is great, right? Like excellent. But once you go, like let's say you do a full arch course, a lot of these courses don't do the prosthetic side of things. And again, you can place a couple implants in, 4 implants on the top, and then all of a sudden you go to put your prosthetic in, and if you don't angle those implants correctly, you can end up with the patient for the rest of their life ends up with this prosthetic that's super thick, right? They went in to get something that was like something close to their natural teeth, and if you don't place those implants, you don't angle them correctly, you don't know how to angle your multi-units, you can end up with a prosthetic that's not favorable for the patient. So being able to see how to manage the prosthetic side as well is insane, super, super powerful. And that's what will put you apart from other dentists when you come out. When I sell treatment to my patients, I get patients that ask me a lot about, they'll come from a general office, a GP office, where they were just going to refer them out to the oral surgeon and then come back to the office to get it restored. And I let them know, like, hey, that is a good way to do it. And I'm sure the oral surgeon will place the implants correctly, and I'm sure the general dentist can restore it well. But what separates our clinics from those clinics is I'm the one restoring those cases. So I want to ensure that my implant placement is perfect. That way the prosthetic's nice and thin. So I'm happy, you're happy, and I don't have to deal with, a frustrated patient after the fact.
Right. And another shortcoming of continuing education too is you'd be very hard pressed to make a course. You can make a course about managing complications, but it's not going to be a live patient course. How do you crowd a weekend course with complications of patients? Like, oh, you're having a complication right now. Well, that's great. We have a course happening in a month. Just hang on for a bit. We got to have run some people through, and they're going to manage this complication. No courses are like that. But in a residency situation, you can do that, and it's important to be able to actually live manage those complications. And I was doing an interview with Jason Auerbach. He's Bloody Tooth Guy on Instagram, and he said, and he's an oral surgeon, but he's very liberal with general dentists doing surgical procedures, so long as they know how to manage the complication. He says, as long as you can do anything you want, so long as you know what to do when something goes wrong. And the issue with that is, if you've just been doing continuing education, how many times have you actually seen something go wrong? You've probably only seen it go right, and you're going to have to run into it in the wild without that support and just, shoot from the hip. And that's just kind of the reality of it. It's like you're not going to see these things go wrong until you're doing them. But in this situation, you're getting the best of both worlds. It's happening in private practice, but you still have that angel on your shoulder that's looking over, that's going to be able to take care of you when you don't know what to do. And so you really found a way to solve that dilemma here. So that's really incredible.
Well, I want to thank both of you, because here we've been talking here for roughly 50 minutes, and not once have we talked about implant dentistry being a specialty.
Right.
But what we've talked about for 50 minutes is making the best educated implant dentist that we can get.
Right.
And I think that means more to a patient than whether you have a CODA recognized specialty from the ADA.
Oh, you bet.
But that doesn't mean anything to the patient. The only thing that patient wants is this a highly educated, highly skilled, and has this doctor who's going to be doing my treatment, have they seen it all?
Yep.
Absolutely.
And
that's the good, the bad, and the ugly, because I don't want the bad and the ugly. I want them to know, and that's what the three of us have been talking about for 50 minutes, is just making the best educated implant dentist, because the three of us have been in the field. Past tense, you current, you're fighting the fire right now every day. You see what happens if it's not done right.
Yeah.
And it's painful.
Tyler and I were clinical directors for a large amount of dental offices that focused on implant dental treatments. And I can tell you the number one thing that kind of drove people out of doing, like, we had a lot of doctors that would come in, they thought they had what it took to do this. And then the second they ran into some more difficult complications, that's really what it could push them out of the field completely, the implant field. And being able, it takes a special person to kind of do it on their own and manage those complications on their own. And that's kind of what Tyler and I have done. But I'll tell you, Tyler and I had plenty of conversations early in our career. Like, man, I don't know if some of these things, they're difficult to deal with. And being able to kind of like slowly work your way up and manage one complication after another slowly, it will put you so much further in the field, because one bad complication, it can really mess with your anxiety levels when doing these procedures, and being able to have someone there for you it helps out a lot when dealing with some of these major complications.
Several of our EPAs are managing a particular complication, surgical complications, or preventing those complications as well, and prosthetic complications. So that is a big part of our EPAs, is just complication management. And another portion of it is preventing those complications. That's what it's all
Right.
about. I want our graduates to come out, and I want them to be successful. I want them to be able to sleep at night. I want them to be able to enjoy their families. I don't want them to go to their kid's soccer game and not be there. I mean, they might be
Right.
physically there, but mentally, they're worried about that patient who's got that open suture line. And what am I going to do now? And all that titanium mesh is exposed, and it's just 1 week post-op. What am I going to do? I want our people to be able to prevent that. And if they do get it, how they go ahead and manage it. And then they have a network, because all our residents, they get to know each other. They bond together. And so I tell them, you know what? These individuals that you are in this residency program with, these 26 other people, they are going to be your colleagues that you're going to rely on for the rest of your life. And I tell them, when you have a good day, I want you to be able to call up any one of those 26 people, and you will not be perceived as bragging, but they will be happy for you because you had a good day. But also, if you have a bad day, you can call them up and say, hey, have you ever had this? How do you manage it?
Yeah.
And as well as all of our faculty as well. They're all very approachable.
Yeah. Yeah, no, that's fantastic. And I think culture in the residency space is super important. And you find there are a lot of programs, and I know people that have dropped out of programs because of that issue, where they felt like it was this very overbearing thing and perfection was expected, and there wasn't a whole lot of humility, and they didn't get that sort of sense of community out of it. It'd just be 2 or 3 residents, and they didn't really feel safe coming to the residency directors or the chief resident, whoever they may be, about some complication they're having. And, something we talk about a lot, not necessarily in the context of residencies, but just in our experience working with other doctors that we've trained or been trained by, is you don't want to work in a silo in this. When you have that kind of bad day, you want to be able to commiserate and get advice from someone else who's run into this before. You don't want to be running into issues that you don't have an answer for at all, or can't find an answer for. And having that kind of community and being able to foster that community in the context of a residency is an accomplishment that, can't really be understated or overstated.
I agree 100%.